Hello everyone and welcome to the 3D Systems e-Simulation Interactive webinar. I appreciate you joining us today and I hope you'll be able to join us for future webinars as well. I'm Nitan Galiani, a product manager in the Angio Mentor simulator team, and I'll be the moderator for today's webinar. In today's webinar, we'll discuss and practice the right heart catheterization procedure. We will start with some clinical background by our speaker and proctor for today, Professor Mladen Vidovic. Then we will have a technical training on the e-simulation so that we can all practice together. Afterward, we'll be ready for the interactive step-by-step training on right heart catheterization procedure. And lastly, Professor Vidovic will answer your questions. Before clearing the stage for Professor Vidovic, I would like to introduce you the Angio Mentor. Our Angio Mentor VR simulator is a training platform for endovascular procedures. We're a huge fan of numbers and we are really proud of our numbers. We support more than 30 procedures for individual and team training in 11 different medical specialties. Our simulators are well validated with over 30 scientific papers. And without further ado, I'm honored to present our guest speaker for today, Mladen Vidovic, Professor of Medicine in the University of Illinois, Chief of Section of Cardiology in Jess Brown VA Medical Center, Chair in the Federal Section of the ACC, and Associate Editor in the Journal of ACC as well. Professor Vidovic, the stage is yours.
Well, thank you very much. I'm glad you organized this, and I think this is a very good way to introduce your platform for remote learning and for mastering procedures in this COVID epidemic. So it's really interesting how we've come full circle, because right heart catheterization, or how it's also called PA catheterization, and then colloquially people sometimes call it Swan-Ganz catheter placement. We used to do it at bedside a lot because this was the standard way of doing this. And then over time, the procedure moved over to the cath lab, just because we became more comfortable doing this with fluoroscopy. But nowadays, we have to rethink the old way of doing things. Bringing a patient to the cath lab who may or may not be COVID positive is a big undertaking. You're moving the patient generally through the hospital, out of the ICU, then you're getting in the elevator, then you're getting out of the elevator. So you're exposing quite a bit of staff to potentially viral infections. It is easier to do this in the cath lab because you have help of fluoroscopy, but logistically nowadays moving COVID positive patients around the hospital is really not a good idea. You are exposing more people to the virus, you're bringing the virus into a cath lab that needs to be re-sterilized, cleaned, just presents a gigantic logistical challenge. And again, those of you who've seen these COVID patients, they're pretty sick. You know, they are on very high ventilator settings. Frequently, they're on dialysis. So again, brings back this procedure again at bedside, which we almost stopped doing, I guess, maybe 15 or 20 years ago. So again, this is a good opportunity to refresh our techniques, how to do it at bedside. So right heart catheterization, the indications are generally pretty straightforward. You need to see what the pressures are in the right side of the heart, and that's mainly in COVID patients is your volume. And given that these patients develop severe lung injury and may become hypotensive because of the vent settings, you frequently have very great difficulty determining what their volume status is. So is this volume overload? Is this ARDS? Are they hypotensive because of some sort of an infection? So mainly, again, in this COVID patient population is volume assessment. As long as you have the volume, you may as well get cardiac output with the Swan-Ganz catheter, and it's a very, very big advantage. I have to say is we used to do this a lot in the early days of Swan, and I don't want to date myself how long ago that was, but again, probably in the last millennium. But then the use of Swan actually decreased quite considerably, because a lot of studies came out showing that Swan-Ganz catheters probably don't extend life, and there were some complications with them. However, again, as I said, we've come back around full circle, and we've really learned is how to use them nowadays, and how to have limited indications. And again, in these difficult patients, it's actually quite helpful to have them. Contraindications this is quite important. Since you're not in the cath lab, you really need to be careful, because you may not be seeing everything you need to see, and you have to be extra careful. So typical contraindications, I think, that are very well known to all of us are coagulation problems. So patients who have low platelets, high INRs. So I think I would definitely stay away from these if you're doing this at bedside, because you may be better off in the lab. Another one is ongoing cardiac infection, some sort of endocarditis. I think this is very difficult to tell these days with COVID, but again, keep that in mind. You definitely wouldn't want to put a Swan in through a infected right-sided structure. I'm sure all of you are aware that COVID is associated with high coagulability, and hypercoagulability has been seen quite often. So known or suspected pulmonary embolism, I think, should raise red flags and probably not proceed with PA catheterization. And then a small one, but again, important one, is left bundle branch block. It's not a true contraindication, but when you're moving your catheter to the right side of the heart, you could cause a right bundle branch block, which again, in a combination with the left bundle, would give you quite a bit of trouble in a patient. So again, keep that in mind, especially if you're manipulating a catheter at bedside without fluoroscopy. And then access site. This comes up a lot. In the cath lab, you can go from essentially any site you want, because you can help yourself with the fluoroscopy to navigate. So femoral site is pretty frequently used in the cath lab, but again, I would strongly recommend to everybody, don't try this at bedside. It is really, really, really difficult to navigate a PA catheter without fluoroscopy from the femoral access route. You could get lucky, and I have to say I've gotten lucky once with that, but again, it was pretty much because lack of knowledge. So just don't do it. I think you should go in the cath lab. If you go from above, your best option is right internal jugular vein. Left is not as easy, because you may have to navigate a little bit around. The one that's really good is left subclavian, but again, that access has decreased in popularity. And the one that's actually not that great is right subclavian. So generally, your best options are right IJ, left subclavian, and then less favorable left IJ and right subclavian, just because of anatomic variations. So on the next slide, what you'll see is your typical PA catheter. So there's some tips and tricks that is really good to look at. Here is these black markings on the catheter. When you're at bedside, you do need to know your distance from the tip of the catheter. And it's pretty much standard. If you look, is the first line is one black line, then it goes 2, 3, 4. And then when you get to 50 centimeters, you get one thick black line. And then you get 60, 70, 80, 90, 100. This is only really 50, 60, 70. You would only really need this from a femoral approach. So when you're going up from the neck, from above, look at these lines. You have to look at them very carefully, because that's your marker where you're at in the heart. And in the simulator, which is going to come in a little bit, you'll see how important that is. And then PA catheters come, just go back for a slide. They come with a variety of manufacturers make a variety of PA catheters. So you'll see there's quite a bit of ports. You can have 1 port, 2 ports, 3 ports. It's important to know which one is which, and usually they have nice colors, but they're important because you do want to transduce the pressure from the distal port. And when you measure cardiac output, you need to inject through some of the proximal ports. So keep that in mind. Frequently, if you're not facile with this, you may hook up to the wrong port and you're going to get wrong measurements. So in the next picture, on the next slide, you'll see the classic tracings of the PA catheter. And you see, so take a look at this, and we'll see this on the Mentor angiomentor very nicely. So as you can see, this catheter is coming from above, and when it's in a right atrium, you have this low pressure squiggly waveform. There's quite a bit of refinement in analysis of right atrial pressure, and I think that's beyond our seminar today's, but again, this is a typical tracing. You will see this in vast majority of cases, unless there's some other serious disease. And then next, once you cross through the tricuspid valve, you will get this right ventricular tracing. It is very typical. You really can't miss it. The systolic pressure goes up, and then diastolic pressure is still low. So you can see how the diastolic pressure is very similar to your right atrial pressure. So that's your right ventricular tracing. When you're doing from the bedside, you know you've actually crossed from the tricuspid valve into the RV. And then when you push the catheter a little bit further, what happens is you cross the pulmonic valve. The fact that you cross the pulmonic valve and that it's competent means that the diastolic pressure goes up. And you see how the diastolic pressure is now up from the RV pressure. And then you have this notch, which is called a dicrotic notch. And that usually helps you quite nicely tell you've made progress and you're now through the pulmonic valve. And then once you continue advancing, the PA catheter will go into the wedged position, which means the balloon will occlude the artery. And now you have this, again, flat tracing. This is really an estimate of the left atrial pressure. Again, it looks very similar to the RA pressure, the one you see on the left. But how you would know that you are in there is, first, your distance is further, and you've passed through these steps. You can't get to the tracing unless you had other previous steps. And then we'll see on the angiomentor how you can do a little tips and tricks to confirm that this is really what you need. So these are the pressure tracings. Swan-Ganz catheter, or PA catheter, gives you another modality which is very important, and you can get this pretty much with anything else. You can do it with echo, you can MRI, but it's almost impossible to get this at the bedside otherwise. Cardiac output can be determined by the PA catheter by 2 methods. One is the Fick method, and the other one is a thermodilution method. Fick is very nice because it really measures saturation in the arterial blood and saturation in the pulmonary artery. The only way you can really get the pulmonary artery saturation is if you have a catheter there to sample the blood. The formulas are a little bit beyond this webinar, but it is 2 ways of doing this. Is you can draw the blood and get pulmonary artery saturation, or some of the PA catheters have a little oximeter probe at the tip, so you can get continuous pulmonary artery saturation. Both work well. The one, the fancy Swan, has extra cable on it, but that will give you a thick cardiac output, and you can continuously measure this if you have a pulse oximetry probe on the Swan-Ganz catheter. The next one is called thermodilution, and that's on the next slide. Is what you do here is you inject a known amount of saline, and that's what I was mentioning. That's why you have 2 ports on the Swans, and then you measure the change in temperature at the distal end. Swans will have this thermistor, which measures temperature change at the end of the Swan. This can be a little bit tricky to do if you have to inject saline. So it's usually good for 1 or 2 times measurement. But if you keep repeating this, you'll end up giving a lot of volume. So some of the advanced swans have a heating coil. They have a copper heating coil. So they heat up the blood just for a very minimal amount. And then at the tip, have a very, very sensitive thermistor, which measures change in temperature. And this one, you can get a continuous thermodilution cardiac output, just like with a PA catheter that has a oximetry probe, you can get a continuous oximetry output. So these are very nice measurements, again, for continuous measurements in the intensive care unit. And if you need the catheter to stay in for a few days or longer, which could be in the COVID patients, this would be the catheter I would certainly recommend. So I think we are ready to do the simulation part. So just let me know when we are ready to go ahead.
I think that we're ready now. And let me know if you want to do it with the fluoroscopy on or off.
So what I would recommend, and I think we discussed this before, and I think it's good to see fluoroscopy, but imagine you just don't have it, because that'll help you understand where you really are, especially if you've not used fluoroscopy. So most cardiologists are familiar with fluoroscopy, but vast majority of people don't use fluoroscopy for this. So I think it's a good way to use fluoroscopy. So why don't we? So here in this simulation, we're assuming we're coming from the from above, and it looks like you were coming from the right internal jugular. So why don't you go ahead and start inserting the catheter? And you would do this with the balloon down, and if you look now, if you can stop for a second, if you look at the module, you'll see that you have a distance, and it says about 14 centimeters. And this is about right. See that 14 centimeters. So on your PA catheter, you cross the first black line. You still see the two other black lines. So you're somewhere in between. The sheets in the neck, they're usually about 10 centimeters, and they usually go. So this means you're out of the sheath, but you're not not in the heart yet. So this is a good time to inflate your balloon. You don't want to inflate the balloon too early, and you would before you get into the heart, you do want the balloon up. So why don't we inflate the balloon? You can see this on fluoroscopy. The balloon is now up. Again, you wouldn't be seeing this, but you want this because you don't want to get into the heart with a blunt catheter without visualization. These catheters have this, they can also be called balloon-tipped flow-directed catheter. And that's actually true. The balloon is helping you flow direct the catheter. I do have to say is you do have to manipulate it sometimes, and the balloon is not the answer to all your manipulation issues, but it clearly does help when you're going blindly from the neck. So next thing here is you'll notice your pressure down there. See the red line where the pressure is. You are in the superior vena cava. And now, I see it's an advanced a little bit. Now it's 17 centimeters. That is the junction between the superior vena cava and RA. The pressure looks about the same, and then if you keep advancing, so let's say we keep going, now we're about 20, 22, so now we're in the right atrium. So it's good to stop here for a second, take a deep breath and see where you're at. So 24 centimeters, that's about right. Pressure is the RA pressure. It is usually low, again, as in this model, about, let's say, anywhere between 5 or 15. Anything higher than that, you're clearly having some pathology at this point. The way you're doing this is you're really standing above the patient, above the neck, and you have to turn your head to the left like this and take a look at the monitor. You'll essentially see you see this very low, squiggly flat line. Another important thing is you got to have the EKG on, which obviously you would have in the intensive care unit. And at this point, you will not see 99.9% of the time any arrhythmias. You could cause maybe a premature atrial contraction, but very, very rarely. Almost any other arrhythmias are not caused at this point by inserting the catheter in the RA. So at this point, you can keep going. This is the time to get into the right ventricle, right? So you just push the catheter in, and it will go in. What you saw on that model of the Swan is they do come in with a preformed, pre-shaped tip, and that tip looks like a little bit of a J. When you start putting it in from the neck, make sure you turn it in the right direction and to position it in the so that your J is in that direction of the heart. Okay, if you turn it the other way around, 180 degrees, it's not going to want to go in the RV. And when you're not doing this with fluoroscopy, you have really limited options in manipulating it. All right, so now take a look what's happening with the pressure down there. So you have that RV pressure, right? So systolic clearly went up from the RA, so there's no way you're going to miss this, and the diastolic pressure stays low. Right? So this is critical because this means you did cross the tricuspid valve. How do you know you're not in the pulmonary artery? You will see in a little bit. The diastolic pressure is still very low. At this point, you may get arrhythmias. Not a lot. RV is usually not that arrhythmogenic, especially with these catheters, and especially the plastic catheters don't cause as much arrhythmias unless you had the wire, but you're not going to be using this. This is the time, as I mentioned, is to look at the EKG. You could tickle the right bundle and cause a right bundle branch block, which again, if there was a left bundle branch block, you would have to be extra careful in this situation. All right, so you determine the RV pressure and you keep going, right? So you keep advancing. You see we're about 34, 35 centimeters, and the catheter will almost invariably, especially when you go from above, very easily cross the pulmonic valve, right? So here you see how the pressure tracing changed, right? So the diastolic pressure went up, and you have a dicrotic notch, right? So this confirms you've crossed the pulmonic valve. Your balloon's still up, and at this point you really shouldn't be having much more arrhythmias because your balloon is now in the pulmonary artery and you're out of the ventricle. Right, so this is a good situation to be in. Your PA pressure, peak PA pressure should be the same as your peak RV pressure, unless there's some condition causing pulmonary stenosis, pulmonary valve stenosis, which again is extremely rare to find. And I don't think I've actually ever found one randomly on an adult patient. But again, it's possible, but your peak RV pressure will be the same as your peak PA pressure. Again, 99% of the time. It would be very surprising to find something else. But your diastolic pressure went up, right? So then you note the distance, about 43 centimeters, that's about right. And then you keep going. The catheter will, as you see, will keep pushing it, will almost always go into the right pulmonary artery. And you can see how it's going to the right artery, so keep pushing. And you just keep going. You don't know where you're at because you're not seeing this, but here now we'll see what happened is your pressure suddenly got flat. That means that the balloon got wedged in the pulmonary artery and occluded the flow. Right? So now you actually got the wedge. Extremely important. You don't know where you're at because you don't see this fluoroscopy, but all you see is the pressure tracing. Right? So you watch the pressure tracing after the pulmonary artery pressure is obtained to get the wedge, and then you note the distance. So you see about 55 centimeters. That is quite generous. It could be less. It could be 40. It could be 60. But note that pressure, and that pressure. Note the distance. You have to document the distance in the chart because nurses will change, doctors will change. You need to know where you wedge the catheter. All right. So now you want to confirm, is this really what I think it is, right? Again, you don't have fluoroscopy. So what you can do is you can deflate the balloon right now, right? So Nitzan's going to deflate the balloon. And take a look what happens now when you deflate the balloon, right? So take the balloon down if you can. Don't pull it back, just deflate the balloon. And see how the balloon went down and the pressure went up. Okay, so when the balloon is down, the catheter is not wedged, and you go back to the PA pressure, right? So this is very nice trick to help you determine you're not in some unknown position and you're close to the wedge. And again, if you now inflate the balloon up again, you'll see how your pressure will drop and the wedge goes down. Okay, so this is a good test to know where you're at. All right. At this point, as you measure the wedge, you measure the PA pressure, you measure the RV, and you measure the RA. You have to take the balloon down at this point. You can't leave the balloon wedged for a prolonged period of time because you will get a pulmonary infarct. Right? So very important is take the balloon down, and what you can do right now is you can pull the catheter back by about 2 or 3 centimeters. Swans, so I would just come back a little bit, right? You don't want to leave the catheter in too deep because it's a plastic piece of tubing. It'll get warm. It's like a noodle. You know, the longer you cook it, the softer it'll get. And when the catheter gets soft at body temperature, it may migrate back and forth. So you're better off just pulling it back a touch. And then when you need to re-wedge it, you can always inflate the balloon and then push the catheter in a few centimeters. That's not that hard to do. All right. So at this point is what you can do is you can measure cardiac output. All right. So how would you do that? Easy first thing to do is draw a sample of our pulmonary artery blood. Where do you want to draw that sample? You want to draw it when you have a PA pressure tracing. So just right now. If you were to draw the sample when you had the wedge tracing, you would get a erroneous sample because you would draw wedge blood and you would get arterialized blood, oxygenated blood. So you want to draw the sample when you have a PA tracing. This looks just like this. So you do that, and then the next thing is you want to measure thermocardiac output. So you take a look at your swan. You make sure you're hooked up with your thermistor to your computer monitor. Usually you need an assistant to do this because you're probably sterile at this point. And then you inject saline into the distal port, and then you'll get a thermal cardiac output. This is best to practice at the bedside on your swan before you insert it because, again, different manufacturers do different swans. So just ascertain yourself to know where you're going to inject before you do it in the patient. And then that's it. You've really placed the swan in at the bedside. We talked about some of the positioning, and I think this is very good on the simulator. Nitzan, if you can go to the overlay, I think this is the nice thing about this 3D Systems Mentor, because it does help you understand things that didn't exist before. And again, I wish we had this when I was in training as an intern, because you had to have a wild imagination to know where you're at, but now you can actually see this, which is really great. So take a look at this. The catheter came from above, right? You know, it came from the SVC, got in the RA, crossed the tricuspid valve, which you see very nicely, then made a big loop through the RV, right ventricle, and then you see how the pulmonary artery is anterior and goes superior, went up, back up, and then made a turn towards the right pulmonary artery. Take a look at the inferior vena cava, right? So if you were to do this from the femoral artery, which we do in the cath lab, it is really tough to make that turn. See, that turn from the RA to the tricuspid valve and then up and around into the pulmonary artery, it's not that easy to do. You need fluoroscopy, and it takes some hand skills, eye coordination to do this. So again, as I mentioned, this is a good example why you shouldn't be doing femoral catheters from femoral PA catheters at the bedside. So please do them from above. Another thing is take a look at the right pulmonary artery and the left pulmonary artery. Almost invariably, the PA catheter will end up in the right pulmonary artery. just because how the catheter is shaped and how the heart is shaped coming from above. It almost never ends up in the left pulmonary artery. Again, it doesn't matter to you, but just to keep in mind what to expect. Once you place the catheter, you'll want to get a chest X-ray just to confirm placement of your PA catheter for medical legal reasons and for good patient care. So this is what you should be saying, right? So just now imagine you're checking on the chest X-ray. You're having this curve that looks like a inverted letter C, and this is what you would be seeing on the chest X-ray. Obviously, this angiometer helps you. So that is in a nutshell how you would do this from the neck with the help of the simulator. So Nitzan, do we have any questions, or how would you like to continue this?
So thank you very much for this outstanding talk and demonstration. And we do have time for some of the questions that you asked. So first, I see a question that was asked before you answered about your preferred approach for doing a right heart procedure. I think you talked about it in the beginning.
Yeah, and I can also say is, if you're doing this at bedside, you do have to use ultrasound for your access site. I think there's really no question nowadays to be safe, to really know where you're at, use ultrasound to confirm you are really in a vein. And I think that's a good question. And you said is right IJ, ultrasound guided approach, it increases safety to a great extent.
Perfect. And here we have another general question about COVID and right heart related procedures or heart procedures in general. From your experience, is there a connection, something that you experienced, read about? No. Is it something that we already know?
Well, I think the main reason in a COVID patient is, I'll tell you from cardiology perspective, is we are noticing that patients do develop myocarditis, and there's been reports of severe myocarditis with severe left ventricular failure. There have been some Takotsubo reports in patients. Some have actually needed ventricular support. So this is where you would, from the cardiology perspective, use a PA catheter clinically to determine what is your cardiac output and what are your filling pressures to support these patients, especially if they need pressors. From the pulmonary perspective, I think that is the classic traditional use of the PA catheter is to determine whether patient has pulmonary hypertension and what is the cause of this pulmonary hypertension. And for that, you do need to see what is your wedge pressure. So if the wedge pressure is low, but the PA pressure is high, that would generally suggest a pulmonary pressure process, versus if the wedge pressure is high and the PA pressure is high, would generally suggest a cardiac problem. Again, this is very simplified, but this is the classic use of the catheter to help you distinguish these two conditions. What we've seen with COVID is you can really see almost anything cardiac-wise, and it's a great mimicker of many cardiac conditions. So that's why this use of PA catheters may be a bit higher in this situation.
Great. This brings us to the end of our webinar, and thank you again, Professor, for the talk and demonstrations. And in the upcoming days, each of our attendees will receive an email with a link to the recorded version of this webinar and a short questionnaire to hear your experience. Your feedback is appreciated and very important to us. If you ask a specific question that we didn't answer, we will be sure to follow you shortly. And thank you again for joining us, and have a good rest of your day, everyone.
Thank you all.
Thank you.